Welcome to the Behaviour Speak podcast. Now, here's your host, Ben Ryman.
Welcome to the Behaviour Speak podcast. Today on the show, we have Alexia Stack. Thanks so much for coming.
Thank you for having me. I'm pretty stoked to be here.
Me too. So awesome. We had a pre-chat a couple of weeks back, and we were just chatting a bit earlier today, and we're going to be talking kind of all things trauma and ASD and kind of how that all relates, and sort of just trauma in general. And we might touch in some, really we could touch on, almost anything, because there's a lot of things sort of in our field, issues, ableism and just some of our practices. And we're starting to hear things from the autistic community around sort of, trauma related to even ABA, although we're not going to be focusing so much on that piece. But trauma is a huge area. But strangely enough, when it comes to autism, there's not a whole ton of research, as I learned from reading your paper, which we're going to talk about. But before we get to that, maybe you might be able to just kind of tell us a little bit kind of how you got into the field, and then kind of how that led you to sort of interest in trauma.
Yeah, for sure. How I got into the field story is not super exciting. I don't think it's like that different from many. Back then, what we were called therapists, and now we're called behavior interventionists in BC, and then also RBTs. So it's not that interesting of a story. I was on my gap year between an undergrad and a graduate program, and had studied general psychology as an undergrad student. And I felt pretty done with the lack of applicability, actually, of the psychology degree to real life is kind of what was doing me in a little bit. I traveled around the world. I came back and I had no work. I was considering going into law, actually, at that time, really deviating away from psychology. I had really burned out. I also, undergrad program I did, I feel like drove home this hyper focus on getting straight A's in order to get into grad school. And you had to have a ton of research experience, and clinical experience was less valued and stuff like that. So I was a little done with it. And then I needed work. And so that state of deprivation for paying my rent and having food and being able to do the things I enjoyed really kind of got me into the field. I had friends who were working as behavior interventionists, and they just said, you should come do this. You love working with kids. You're good at it. And that's kind of what I did. So I started working as a BI. I had worked as a camp counselor when I was younger at the YMCA in Alberta, at an overnight camp and at day camps and stuff. And I had coached basketball. So I had that, I loved working with kids. I always knew I loved working with kids. But I was really done with psychology, actually, when I had graduated. So yeah, I started to work as a BI. I got hooked because it was the exact opposite of what I had experienced in school. You could see the direct application of a science in practice, and it produced such reinforcing results, I guess, to be working in that kind of environment. And so I just continued doing it and decided to go to grad school at UBC before they had a course sequence in ABA, a long time ago at this point. That's kind of how I got into the field. Nothing super interesting. My interest in trauma, though, I think there's a lot of different things here for me, if I look back at it. I think that in some ways I've come back full circle to where I started when I left high school. In high school, was really interested in psychology, and I studied everything relating to schizophrenia and what was once called multiple personality disorder and is now called dissociative identity disorder. So I was really interested in that. In high school, I did presentations on it. I took I don't remember, an elective in high school in grade 11 or 12 on some psychology class that was so poorly taught, but I loved it regardless. I don't know if I even learned anything, but I was like, this is awesome. I'm studying psychology in high school, and that's pretty cool. So
totally.
And those kind of the mental illnesses that I was really interested in, schizophrenia and dissociative identity disorder, are pretty interconnected to trauma. So if I look back to when I was pretty young at the time, 16, 17 years old, I think I already had kind of an interest in it back then. And I didn't really know where it was stemming from or coming from, but I was into it. And I also worked in a attachment lab at SFU for a couple of years under Dr. Kim Bartholomew, who is a highly well-known, highly regarded attachment researcher from Stanford originally, and then she came up to SFU and taught there. So I worked in her lab for a couple of years and did some scoring and some pretty interesting work there. So yeah, those are kind of the connections through my schooling and stuff. I also, I guess, have some, I mean, anybody who's going to be interested in trauma is going to have a little bit of a personal history with it.
Sure.
So, to touch on that really briefly, the family is, they're World War II survivors. We're Polish Jews. So,
wow.
Yeah. So if you kind of can imagine anybody coming from that context, my grandmother
Absolutely
survived the war, working as a nurse with forged documents. So she pretended to be Russian and she pretended to be French, I think. And she moved kind of from army to army throughout the Second World War. And she lost her mother, her sisters. She lost her first husband in the war. And so that's obviously going to kind of take a toll on a family and going to leave an imprint across multiple generations. So
yeah. I was totally thinking like intergenerational trauma there. I mean,
for sure.
We hear a lot about that with, well, maybe not enough, but I hear mostly about that sort of area when it comes to sort of, First Nations kind of related trauma, and they talk a lot about the intergenerational, but I never even considered sort of, anyone who's ever been in a war, and how that can affect sort of the family for generations.
Yeah, I definitely think and know for sure whether you're on whichever side of the war you're on, I guess, whether you're fighting in the war, obviously back with severe PTSD symptoms in most cases. And that's going to kind of carry down the family lines until somebody tries to kind of break away, heal, and change and stuff like that. And
100%. Yeah. I never even thought about sort of, I know we talked about how this topic could totally go down so many rabbit holes. But I never even thought about sort of that idea that the trauma, I mean, you experience the trauma, but you didn't experience the event per se. And so the idea when we're doing, assessments and those sorts of things, and we'll probably get to that later, sometimes we're looking for sort of the source of the trauma, or at least was there some kind of trauma? And I would never even think to sort of ask, did your grandparents experience trauma? Did your great-grandparents experience trauma, as a question to sort of assess whether you're experiencing trauma?
Yeah. I mean, even if you think about it gets encoded genetically, and I don't know a lot about the genetic encoding and how it's changed as a result of trauma, but there is research that shows that DNA changes as a result of trauma in a family history, and that gets passed down. But if you think about, for example, my grandmother, and we're kind of going on here a little bit, but she was the most loving human. But when she was upset and angry, she went from 0 to 400 without any cue that something was suddenly going to change. And that came just, from her history. It was an extreme level of emotional dysregulation. And that extreme presentation of I'm cool and I'm okay and everything is fine, to I am yelling at the top of my lungs right now, and what's happening in the environment and in the context doesn't match. There's no reason for such a high level of escalation, right? But if you really looked at her history, there were just so many environmental triggers for her that, as a young kid, you have no idea what is going on and why it's going on, and you have no clue what's happening, right? But your grandmother is the lid. And then, that's just an extreme response to trauma, that level of emotional dysregulation. She's probably experiencing some form of flashback in that moment, but you really can't identify it as that, right? So that is going to for sure impact the family. And how many families have survived different kinds of traumas, if you think about it, like our families who have come here as refugees, for example, that's going to come with a whole bunch of different stories and, setting events and histories behind that really are going to then affect our clients directly themselves, whether or not they themselves are experiencing trauma in any way. So,
yeah. So, wow. So, just maybe one more kind of question about family. So, when did you kind of make that connection that this is not only has this affected your life, but that it was a result of stuff that didn't even happen during your life?
The connection to family, like the real deep understanding that their life histories had an impact on my life story,
Yeah.
where I could really make sense of it as an adult, for sure.
Right. Yeah.
As a kid, I knew something was not okay and something was off and stuff like that, but you can't
Right.
articulate it and you don't really make sense of it and stuff like that until
Gotcha. Wild. So, okay. So, you do have sort of that typical story that I often hear of how folks kind of get into the field. I won't get into my story for the sake of time, but I didn't go the route of the BI. And so whenever I hear that, I'm like, well, that's the typical story for a lot of folks. But so you're in your undergrad, did you learn, was there any courses on behavior analysis? Because I often hear, I think it's different for us in Canada, but because we don't have as much of a history there in terms of ABA. I mean, we've got, a few folks here and there. We've got some history in Saskatchewan with, the behavioral engineer paper there and some stuff that happened in Manitoba and, a little bit here and there. But when I often hear, on sort of a lot of the American podcasts, the story will be about, I went to Michigan for my undergrad. And of course, there was already a ton of ABA happening, and so there was an intro to ABA course, and it happened to be taught by Jack Michael or whatever, and and they have that whole storyline. But up here, I know when I took my intro to psych, I had a psych degree as well, and I think we had one course called Learning, but I don't remember hearing anybody's name except maybe Skinner on a couple pages. So was there any ABA in your undergrad?
No, I went to SFU and did a psychology degree there, and I took a course on behavior disorders, of all things, and nothing other than the same thing, a couple pages in a textbook about Skinner. But the behavior disorder and treatment of behavior disorders had nothing to do with applied behavior analysis. So, no, it was
interesting.
Psychodynamically oriented psychology program.
Right.
Nothing to do with behaviorism, right?
Which is so wild because, of course, all that stuff was happening while you and I were, even in high school and beyond, but it just didn't get sort of disseminated up here, I guess. So,
no, totally not.
So you kind of got that interest in trauma. When did that kind of intersect with the ABA work?
Yeah. So that's a perfect question. I think pretty early on as a behavior interventionist, like the first couple of months that I worked in the field, I was already alerted to some of the procedures that we were doing with those families and with those kids at the time that were highly aversive. And I often reflected on the work that I was doing, compared it to what I was taught when I was working as a camp counselor and volunteering, working with kids, and never, ever in a million years would anybody have ever recommended some of, the things that I was being taught working as a behavior interventionist. So that was like a little bit of a kind of a probably red flag if I think about it, as to what was going on back then. And then I would question what I was doing. I left some of the teams I worked with because I didn't really believe in the philosophies and the practices. And I think that kind of sparked my interest, but I wasn't super aware of where that was really going to lead me to. And I think that really when I started working as a consultant and going into families' homes and taking on, really seeing the bigger picture outside of just my one-on-one table work or play work or out in the community-based work or whatever. It was really walking into families' homes and realizing and noticing the huge amount of stressors that families were living in and under, parents going through divorces, levels of poverty that varied at times, managing really stressful school situations, really noticing what was happening in a family home on a daily life. And I started to think a little bit more then, like, there's probably stuff going on here that would be considered to be a trauma for some of our kids or a trauma for some of those parents and stuff like that. And so really listening, looking and watching what was going on in my environment as a clinician, I think opened my eyes up kind of even more to what was likely happening for the kids that we work with as well. So, yeah.
Mm-hmm. And you're still a BI at this point?
No, I'm a BCBA.
Oh, you're okay.
I do work with my kiddos on my caseload. Like, I think it's really important to have direct contact and stuff like that. Yeah.
So when you were, you said when you were working as a BI on teams, though, you kind of experienced some aversive practices, possibly.
Yeah.
And so, first question is just, so when are we talking? Because when a lot of people think about sort of the aversive practices of ABA, they're talking 70s and 80s, and I definitely don't date you that far back.
No.
So,
Very early 2000s, like 2000.
okay,
Yeah.
so it's like 21st century that we're talking.
I'm not talking about on a child's face or like slapping a desk or anything like that, but
No.
Even the use of informational no's, for example, and then today that I would view an informational no when working with a child. And then I remember specifically being trained at one point on how to deliver more aversive informational no's for a learner who is really struggling to learn. And that was a pretty big wake-up call for me. I was sitting in a workshop and being taught for 8 hours how to be more aversive, which was very questionable ethical practice at the time, obviously, and today as well. So
I don't know what you mean by informational no's.
So when you are delivering like discrete trial instruction, for example, and you present an SD, what this, and the client makes a mistake and you say no in response before you enter some sort of correction procedure.
Okay.
No. Or if the client is engaging in an undesirable, maladaptive problem behavior or something like that, delivering a no as a piece of like, no, you shouldn't be doing that. So,
okay, gotcha.
Yeah. And so as part of the teaching protocols, that was pretty common with a lot of the teams that I was working on at the time was no after every single trial where an error was made. And, that was in retrospect, when I look at that, and I've been thinking about that for many, many years as a practitioner, that was obviously, problematic in many ways, but then the specific training about how to make your voice like sharper and louder and kind of literally more scary for a child. So the child would be more responsive to that no because they weren't responding well enough to being told no, essentially. That's pretty messed up stuff for 2001, 2002. So
100%. Yeah. And I even considered sort of, I think when everyone thinks of sort of aversion, they're thinking, well, obviously the corporal punishment, but they're also thinking like, the lemon sprays and the ammonia sprays and some of these kind of, noxious, stuff on the thumb so you don't suck your thumb or whatever. But just saying no to someone, I wouldn't have considered that, but the way you describe it, it could potentially be like hundreds of times a day, even depending on sort of the scenario.
Oh, totally. I mean, if you're like being taught for your trials to go quickly, and and back then, so many families had 40-hour-a-week therapy programs too, right? And so 40 hours a week of intensive instruction, and the learning trials are happening like one a second. And the rate of the error rates are super high, right? And so just no over and over and over and over again, in and of itself, could potentially condition a fear response to people. And I kind of was going to touch on that later, but just that repeated no. I mean, over and over and over again, and then being trained to be aversive when delivering a no. Or we use noxious substances, things like DRLs, for example. Like a DRL, if delivered properly, is meant to be a reinforcement system. But if you're really trained in the implementation of the DRL in and of itself can be pretty punitive. And I had some pretty bad experiences being taught how to implement DRLs as well. And so for years and years and years after I stopped working with some of these different teams, I wouldn't touch DRLs as a system for, behavior reduction. Basically, I was terrified of it. It was pretty aversive to me to implement it. So, yeah.
If you're planning on collecting CEUs for this podcast, you'll need to know the 3 secret words. The first secret word is trauma. And so what would that look like? Because we're talking about differential reinforcement of low rates of behavior.
Yeah. So let's say, for example, we're working on reducing a behavior from occurring, 5 times every 20 minutes down to 4 times. And you have like a little visual token board every time the kid engages in the undesirable behavior. You move the token, you pair it with a aversive no. And at the end of it, if they were working for an edible, for example, you eat the edible in front of the child. Like,
oh, wow.
2001, right? Now you're instructed to eat the edible in front of the child, right? And how many kids are going to sit and cry as their trusted behavior interventionist is sitting and eating their treat that they didn't earn in that, I think I gave the 20-minute period as an example to start with, right?
Mm-hmm.
So, yeah.
I just wonder what I don't come from an early intervention background at all. All my experience has been with adolescents and adults and seniors and that sort of thing.
Mm-hmm.
And so, when people talk to me about sort of, some of these early intervention protocols, I'm starting to have more of an idea what they're talking about, but I'm still not getting. So would this fall into that low VAS category? Is that what that was, or was this before that, or was this part of that? Or?
Yeah, that's when I was doing some low VAS or discrete trial teaching work. At the same time, I was being trained in other methods as well. So my experience in the low VAS world didn't last too long. So
just maybe tell us a little bit about kind of what you're doing now.
Mm-hmm. So in terms of my practice and stuff like that.
Yeah, well, and you have a company. What's it called?
A Block Above Behavioral Consulting.
Block Above, right? Okay.
Yeah. So, I'm doing early intervention work all the way into adulthood, like midlife adulthood. My personal areas of passion have really shifted a lot over the years. When I was younger, I was like really into the little kids, the little itty bitty ones. And I found that as I've aged, maybe my energy levels have shifted or something like that, but I've really aged with my clients. So I really enjoy working with youth actually, and adults, as well as children as well. Like I still really enjoy that work as well, but I actually find it more challenging to be working with older learners because the histories of learning are so much more complex. So you end up then with individuals who are suffering with a range of different kinds of mental health issues, in addition to, having learning challenges and language development challenges as a result of being on the spectrum. So that's kind of my own personal area of interest when I work with families. And I am also going back to school at some point in the next 8 months or so. So, yeah.
Okay. And what's going on there? What's the plan?
The current plan that I think I'm pretty set on is to just get a second master's in counseling psychology, actually. So
right.
Yeah. Mm-hmm.
And in there, would you be kind of focusing on sort of this trauma area?
Yeah, that's definitely my area of interest.
So maybe with that, we can kind of dive in a bit to the paper that you did. So this was after your master's degree. So this was sort of just something you did after completing grad school. You kind of went back to UBC and did a little work with Joe Lucician. Is that right?
Yeah, that's totally right.
That's right. And then and you published this paper, and folks have heard it in the bio already, but it was called Autism Spectrum Disorder and the Experience of Traumatic Events. Review of the current literature to inform modifications to a treatment model for children with autism, and that was published in Journal of Autism and Developmental Disabilities in 2018, and we'll have a link to that. And then I see it, and then later on you did or just recently here, this chapter in Fred Volkmar's book that also kind of covers autism spectrum disorder and the law, which sounds like it's going to be a pretty amazing title. So what's this paper about?
So this paper is basically a model for an intervention to treat trauma in children with autism. I wrote it as a PhD requirement. I was planning on doing my PhD and have been mulling over that since I wrote the paper, and not sure about a PhD at this point in my life and its applicability, and my desire is to pick up and uproot my family at this point. So I kind of decided to step away from that and do a second master's, actually. So it was originally just a requirement to get into a PhD program. So I worked on that for a few years with Joe, and anyone who's worked with Joe will know that process takes more time than you ever anticipate it taking, getting through writing a paper. But I learned so much in that time with Joe, and it was definitely a very eye-opening experience. And so basically what I did is I looked at the research in the area of autism and trauma. And like you've mentioned, there is, even today, 2 years later, there's almost nothing out there. So we continue to know very little about trauma and how it plays out in kids with autism, or even teens and adults with autism. Its prevalence rates, we know virtually nothing about it in our population that we work with. There are no evidence-based treatments for trauma in our population. We don't know about the effects that trauma has on, again, kids and adults on the autism spectrum. So there is room for research in every one of those areas, and many more areas, basically, in regards to individuals on the spectrum. So I basically went to the literature in typical development in order to kind of cover what is trauma and how does trauma affect a typical person's lifespan. How does it affect their learning? How does it affect their emotion regulation, pain on the body, and so on? And then what are the treatments for trauma in children? And then I used all of that information in order to inform the development of a treatment model for kiddos on the spectrum. So I developed that model with Joe's support, and then we published that paper.
That's crazy that for all the stuff that we're talking about right now, I mean, trauma and autism is, a really, I don't know if fad's the right word, but it's a big topic right now. A lot of people are talking about trauma and autism and not only how the possibilities of, interventions causing trauma, but just sort of the inherent, nature of the characteristics of being autistic. The people are often alone. They often are lacking social contact. They're often some of them are engaged in self-injury and different kinds of kind of self-inflicted behaviors. There's a whole gamut of reasons why a kid with autism could experience trauma in just sort of daily activities, daily interactions, not even sort of abuse or neglect or anything like that, which we also see a lot of them. I mean, we see a ton of that piece, which is sad. We also see a ton of divorce in families with autism. So there's going to be sort of that have kids with autism. So there's going to be all those pieces, but, and so it's mind blowing that we don't have any research on that.
Right. And it's mind blowing that it's such a hot button topic. I mean, you and I are both in a lot of the same different kinds of social media groups. We see in there and stuff, and people are talking about it absolutely everywhere. There's for sure a business practice that's evolving and emerging in the US in particular around, trauma and autism. And yet there is, frankly, basically no research in the field. So, and yet, exactly like you said, we don't know what the prevalence rates are, but we know roughly what the prevalence rates are in children. We know that kids on the autism spectrum are more vulnerable, more susceptible to experiencing a broader range of events in their lives that may be traumatic. And then also exactly like what you said, what could be a pretty neutral experience with a neurotypical child may actually be perceived as a traumatic experience for a child on the spectrum. So there's biological sensitivities that we're not very aware of yet right now either. So there's so much that we literally don't know in this field, but yet it's so popular and it's everywhere right now.
Exactly. I even think of just sort of, the sensory kind of component and folks that, I knew a kid, for example, who I remember we were hanging out in the park and he told me, a train was coming. And it came 20 minutes later because he could hear the train because he had such, crazy hypersensitivity to sound and, of course, loud noises. Obviously, we've seen that a lot as setting events for a lot of the folks we support would just be super traumatic. And it reminds me of sort of, watching, and this will date me, but watching Tour of Duty on CBS, and the military, it was a military TV show, and it was always talking about flashbacks and things like that, and sort of those pieces. And I imagine these kids are kind of having these same experiences. But it also makes me think about sort of, we're talking about being in a lot of these social media groups together and seeing a lot of this discussion right now, and a lot of and a lot of it's around ABA and whatnot, and we're seeing some well-known folks in our field, BCBAs and whatnot, BCBADs, that are sort of putting out the research on ABA as sort of a way to kind of defend their work and defend what ABA is all about. And the thing I keep kind of going back to is that we don't have any research to kind of come back with ourselves. We don't have any research on trauma. We don't have anything to actually prove that, it's not really important to me at this moment to prove that, early ABA may cause trauma. It's more that there is trauma in general, and that they experience trauma, and they have a lot of trauma, and that we have to be a lot more kind of trauma informed in kind of the work we do. I mean, most of the trauma informed kind of supports that I see are with the kids you described when you were doing your review, typical kids, in kind of school settings that have obvious sort of adverse childhood experiences, of divorce, abuse, neglect, and poverty, and all those sorts of things, addictions, and all those kinds of things. But for these kids with autism, I mean, we often talk about how the kids with autism, I used to talk to parents of kids with autism who say, at least my kid's never going to be a drug addict, for the kids that are kind of maybe more severely affected.
Yeah.
Sure, but that doesn't mean your kid's not going to experience trauma.
Mm-hmm. Exactly.
And so what did you kind of come up with in your research? Because your research sort of found sort of the stuff a lot of us already know about trauma, but there's also a lot of stuff I think that we don't know. So what kind of key points did you find kind of in the literature review kind of part of your study?
Yeah. So in terms of like the lit review components, I looked at like I said, neurobiological effects of trauma.
Mm-hmm.
And so kind of looking at that area, again, everything that I did was informed by the research in typical development. And we basically drew conclusions to how this is likely going to affect children and adults on the spectrum as well. They're humans, they're animal beings. They're not going to be any different in how trauma is going to be affecting them, how it displays itself, how it shows itself. That might be a totally different story. How we can treat it, possibly maybe a different story as well. But in terms of like the neurobiological effects, we know that trauma, it affects the limbic system in typically developing kids. And the limbic system, for those of you guys that need a bit of a refresher here, I usually need a refresher too, but that's comprised of the amygdala and the thalamus and the hypothalamus and hippocampus and some other structures as well. We know that being exposed to a repeated traumatic event or a chronic trauma can cause changes in a person's neural structures, so they physiologically change, as well as to their sensory systems, which is super interesting that you pointed out. Working with the kids that we work with and the adults and youth that we work with, and they have like those hypersensitivities to their environment. There's this parallel between possibly the non-traumatized brain in individuals with autism to the brain of somebody who's experienced a trauma. Even before, an individual may experience trauma and be on the spectrum as well. So there are some similarities to the brain that way. Also, we know, or we've learned that when there's a psychosocial stress in the environment, and that is picked up by the hippocampus and the prefrontal cortex, basically is responsible for kind of getting the amygdala going. It sets off the firing of the amygdala, which triggers a part of the nervous system into a fight or flight response. And so I think people are more familiar with the fight or flight response these days. And also, like, the amygdala is responsible for processing emotion in the brain. And so it also is responsible for eliciting a fear response. So it's basically evaluating, is there a threat in my environment? Is there no threat in my environment? If there is a threat, I should be afraid of something, essentially. And so the amygdala is being triggered in those kinds of situations as well. And that then sets in response the firing of the sympathetic nervous system and parasympathetic nervous system. So that's kind of, we looked at the limbic system quite a bit in our work. We also looked at motion regulation being a really, really big piece of how individuals on the spectrum are affected by trauma. So just like in typically developing kids, when they experience trauma, there is either emotion regulation that's adaptive that occurs or emotion regulation that's maladaptive that occurs. And so in terms of adaptive emotion regulation, it's basically the ability to reappraise your story and to change it in such a way that you come out of that experience with a balanced perspective of what happened to you, essentially, right? And so some individuals are able to regulate more effectively than others, and they're therefore able to narrate or rewrite their experience in such a way that they'll necessarily have experienced that event as a trauma, or it had less impact on them, or they are able to make sense of their story early on. Whereas people who engage in emotion suppression, which is pretty common when you are experiencing a lot of trauma, and it happens over and over and over again. Also, we know that many kids on the spectrum engage in emotional suppression as well as a regulation strategy, right? They basically push the feelings away in different ways. And so the suppressing of the feelings is often associated with trauma, the pushing them away. Sometimes people dissociate from their memories, from their emotions, from their bodies and stuff like that. And that's all, said to be maladaptive. So that happens in typical kids. And, I'm sure see it happening in the learners that we work with, and we see fluctuations in their abilities to regulate emotion and stuff like that. Right.
Mm-hmm. So I see there's something you said kind of earlier on there. First off, all that neurological kind of information, I think, is just really important for folks to kind of remember that trauma is a huge biological component, and it's not just I had a bad day and thought about it, and so that's why I'm acting this way. Like there's stuff happening in the brain, like actual changes, and I know, I have ADHD, and so I know that. That there's actual chemical sort of error happening with my frontal lobe somehow that causes me to think about things a certain different way or affects impulse control and all those sorts of things. And so, the folks that are experiencing this trauma, often have no control over kind of, some of the stuff they're engaging in. It's almost kind of reflexive. I thought it was really interesting when you said, we were talking about sort of the brain similarities between folks that have experienced trauma and those with autism who haven't experienced, the kind of trauma that we talk about, and that they look similar. And so, because from what I understand about trauma and what you've been saying already, there's a lot around hypo and hyper arousal, right? Is that right?
Yeah.
And so. And this is sort of something we hear early on when we learn about autism, that they're often hypersensitive or hyposensitive to certain things. And so the idea that their brain is already, that way is so wild to think about.
Yeah. Well, actually, there's a couple of different researchers that write about that. There's Connor Kearns, who moved up to UBC a couple of years ago from the States, and she published what I consider to be a pretty seminal paper in 2015 in the niche area of trauma and autism, where she touches on a whole bunch of areas as well in her paper. And she touches on the brain, she touches on emotion regulation. And then also in that paper, there's reference to an article that was written in 2010, by Wood and Gatto. And they also talk about hypoarousal, and again, similarities between trauma, emotion regulation, what happens there, and then the whole idea of emotional suppression, emotional regulation. Yeah. Anyways, I feel like I've shifted a little bit from what you just said, and I forgot what you just were saying. I'm so sorry, Ben.
No worries. It's just, there's so many different directions you can go with this stuff. And by the way, we'll have links to all the articles that you reference in show notes for folks to check out later.
One thing we forgot to touch on, I don't know if it's worth it, but we haven't really defined trauma for people. I don't think that's something like that we need to do. I don't think
Let's do it, because I was actually having a discussion with one of my mentors just yesterday about this, and I was labeling something trauma, and she kept telling me, "Nope, that's not trauma. Nope, that's not trauma." So maybe I don't even know what trauma is. So I'd love to hear it.
Okay, well, there's a bunch of different definitions of trauma. That kind of tends to be the way things go, but there's some that definitely really resonate with me. So very generally speaking, trauma is a wound, right? And it's gonna be a wound of some sort. It's a wound that's going to lead to the development of fear. So at the core of trauma typically is a fear response, and that can generalize across a really broad range of stimuli. So I, for example, may have experienced, I don't even have an example at the top of my head. Let's say I experienced severe ongoing bullying at school. Every day I go to school, I'm being bullied by my peers. The fear that environment then evokes in me every time I go to school, I'm afraid to be there. I'm afraid of my peers around me. I'm afraid to make a new friend. That can generalize outside of that environment. And so what happens with trauma is that fear will generalize. So I may then be going to like basketball practice, and I get to basketball practice, and suddenly I'm afraid of the coach, and suddenly I'm afraid of my teammates who I've known for a really long time. I then go to a job interview, and I'm at a job interview, years later, fast forward or something like that. And I'm interviewing with someone and I'm afraid of the person that's in front of me. So the fear can generalize across a really broad range of areas and really impact an ability of person to function and to live a really good quality of life. Another one that I really like, it's kind of like the opposite of being connected to people. It's disconnection from people. And one of the things that people often talk about who've experienced trauma is that they really struggle to trust people. They struggle to engage. They struggle to be in the present moment with other people. Trauma, it can also be a physical injury, right? So it can be a serious accident. It can be being born prematurely, for example. And then it can be a psychological injury. So when I talk about it, I kind of tend to talk about it from the psychological perspective, but there are physical and medical traumas as well. So that's kind of one variable. Then there are traumas that happen once, right? The event happened a single time. A terrible example of that would be being raped, for instance, if you're raped once. Or it can be repeated events. And so you kind of have touched on them as you've been talking, actually. So emotional neglect, physical abuse, emotional abuse, sexual abuse, and so on. And you also touched on the ACEs as well. So that's kind of a study that came out in 1998 by Felitti and his colleagues. And that was the first study that really showed the connection between the impacts of trauma into the future. And so he basically, developed and created this list of ACEs, like you said, the adverse childhood experiences. And there's a list of ACEs that likely contribute to medical illnesses, early morbidity, and things like that as well. So trauma, like you said, if it's a psychological trauma, it has a physiological impact on the body. It affects the brain, it affects the nervous system. And some people go even further to argue that it's stored within the body. So rather than trauma treatment happening, for example, at a cognitive level, talking about your trauma, treatment should happen from a physiological perspective. So that's kind of, some of the different definitions of trauma that I like, but it's important to remember that it's a spectrum and it affects everyone differently. So you might be able to go to school and get bullied 5 times by the same group of peers and be okay. You could walk away unscathed, but I may not be able to have that same experience. I may go to school, I may get bullied 5 times, and I may walk out of that pretty traumatized. So that's kind of where individual differences play a pretty big role as well.
I think you make a really good point about sort of, it also doesn't have to be a multiple event cause. You don't have to be bullied 5 times. You could be bullied once. You could, like you said, you could be raped once. You could be abused once. You could have, a major injury once. Now, major injury, head injuries, I suppose that's a whole other game, because now we're actually talking about, actual physical lesions in the brain, and that's a whole other game. Still trauma related, that they do call it traumatic brain injury for a reason. But we won't get into that area too much, although it is definitely an area of importance in our field. And so kind of going back to sort of folks with autism, a lot of these sorts of well, things we just don't even think about that are happening sort of all the time for them, particularly going back to I like the sound sensitivity example. I mean, if they live in a city, I mean, they're being bombarded by this aversive, stimuli over and over and over and over and over and over and over again, like thousands and thousands and thousands of times, a week. It almost makes you sick just sort of thinking about sort of, what some of these kids are exposed to. The second secret word is assent.
Mm-hmm. Absolutely. Yeah, for sure. We have no real way of knowing, right? So. And
then with the ACEs, I think it was, and I always pronounce her name wrong. The one that, the cusp emergence, Camille Kolu. I heard her, I think it was her talking about, I think she described the ACEs, and I think she changed the C to like conditioned experiences, to point out that it's not just kids that are experiencing. You don't have to be in childhood to experience these events and then have that effect on you.
Totally not. No, I mean, trauma is something that can occur throughout your entire life, right? Depending on, again, your environment and what you come into contact with on a daily basis. Arguably, and a lot of people will say that us living through a pandemic right now will be experienced by a large majority of us as a trauma. And we, in the present moment, have no idea how it's going to impact us down. So, 100%. I think I'm okay. I think I'm pretty resilient. I think I'm pretty fine. I'm doing well by my family right now. But in retrospect, there might be a different story, right? So
absolutely.
And that pandemic is not on that list of ACEs. So
no, it's not. No, that's fine.
Definitely not.
The Spanish flu was sort of before that. So you did the lit review and basically you found you learned kind of about the biological and physiological kind of connections to trauma, and then I think you kind of started to go through some of the I guess the treatments that are out there for typical kids.
Yeah. So back to the lit review. One of the small area I really want to point out that we know a little bit about in kids with autism actually, and is in regards to their behavioral symptoms when they've experienced a trauma. So just kind of to summarize, the data suggests that children with autism experience similar symptoms to those that meet the diagnostic criteria for PTSD. So that's definitely an important thing to point out. And that there is an overlap in symptoms in children with ASD who do not necessarily have reported histories of abuse. So sometimes basically what that's saying is that the symptoms can be similar whether you have autism and trauma or autism without trauma. The way that behaviors are expressed can look very similar. And so that's what we call diagnostic overshadowing. And that's what makes figuring out or pinpointing or finding trauma essentially in the kiddos that we work with really challenging, because the kid who's sitting over in the corner scratching his arm yesterday might be scratching his arm today, but between yesterday and today, maybe something bad happened to him. And so maybe today the quality is different. So he's pressing a lot harder, or maybe he's now scratching with an item, whereas yesterday he wasn't scratching with an item. And so that's really important to point out, because it's very hard to see the differences between what is autism, what is trauma, and I'm going to throw one more in there. ADHD is another one that looks really similar. So especially in, I hate to kind of use the term, but in learners who have more advanced language skills, who are integrated into the regular classroom environment, kind of learning at the same level as their peers, have maybe some social deficits and so on. But with those kids, it's very difficult sometimes to tell the differences between what is trauma, what is autism, what is even ADHD. So,
That's huge. I've never heard of that diagnostic overshadowing. And that's kind of scary, because I think about a lot of the folks I supervise, the cases that kind of, that we've come across over and over again. And with trauma sort of being at the forefront right now, we're looking at a lot of these sorts of behaviors and going, things like smearing, like you said, self-injury, hiding under a table, and so many more. And we're going, well, for sure there's trauma. There's got to be trauma in that kid's life, especially if they're like older kids or adults, because, in maybe like a staffed residential setting. So we make assumptions that they've been pulled out of the home for some reason, and jump right to trauma. And maybe they must have been abused. And of course, making that assumption can be, problematic too.
For sure. Think of like the implications behind that, right?
But I love the idea of sort of looking at, I'm definitely going to pay more attention, but looking at the quality, like you said, of the behavior from sort of, point A to point B. Like you wouldn't necessarily be watching for that.
No. Like, how often are you paying attention to yesterday's head hitting was happening at, this rate, whereas today's head hitting is happening at this rate.
Yeah.
And also there's a change in intensity. And that was actually a component of our treatment model, was the functional behavioral assessment. And it's different. Like Dr. Camille Kolu, trauma-informed FBAs. And her whole thing is trauma-informed applied behavior analysis. And so she talks about trauma-informed FBAs, and she talks about understanding the history and understanding the history in great depth, because that will then help you understand whether or not there's setting events at play. But here, what I'm looking at really is I'm looking at already existent behaviors, right? Maybe I'm working with a client who has a list of 3 or 4 different kinds of maladaptive behaviors. But then either something new pops up, for example. So like you said, like, well, all of a sudden I have an 11-year-old literally running under a table, curling their body up into a ball. They've never done that before. That seems pretty unusual for an 11-year-old to be doing, whether or not they have autism, to curl up and to go into like that kind of like a self-protective body position, essentially. And then, so there's like a new behavior that pops up that's different than all the other ones. Well, where is that coming from and why? And also then, like I said, like the change in rate or the change in quality of the behavior, the change in its intensity, for example. And so that can be indicative of a potential trauma, right? And so with the population that we work with who can't articulate, something bad has happened to me. I mean, a typically developing child who's experiencing trauma can't go to a trusted caregiver and say something bad is happening to me. How do we expect the kids and the adults that we work with to be able to go find a caregiver and say, hey, something not good is going on to me, right? So like, we have to be super astute observers. And I'm not saying that every family's home or every group home that you walk into, there's trauma happening and it's ongoing and it's there and it's present. Like, I'm not suggesting that whatsoever, but I'm definitely suggesting that, when you're looking at conducting an FBA, maybe you do need to look at it from a trauma-informed perspective. So
100%.
Yeah.
So, and we're gonna. I want to get on that soon on sort of kind of the model, but you did sort of talk about some of the therapies that are currently being used on sort of typical kids with trauma, and what are folks doing there?
Yeah. So like the most robust therapy is going to be trauma-focused cognitive behavioral therapy. And it has the biggest body of literature currently. I also think that just kind of implicitly, when you're evaluating the effectiveness of CBT, because it's rooted essentially in behaviorism and it's super observable, you're going to get really good results from doing research in that area, right? There are other areas of research that are less robust or emergent practices, or, don't necessarily have much showing whether or not they're effective at this point. And they tend to be kind of like body-based approaches to intervention,
right?
Or like, what is it called? Oh, it's slipping my mind right now. One of them I'm just totally forgetting, but the research behind it is less robust. So our model really was informed from a trauma-focused CBT perspective. But in retrospect, kind of like after I had submitted, after the paper had gone into print, I was like, I really wish I had focused on some other areas as well, but that's okay. That's the past. And then also like ACT-based approaches as well, right?
Well, that's what I was going to ask. Yeah. So
yeah. My big thing that I'm really missing is the ACT component. And I knew about it when I was writing the paper and I was starting to learn about it. But I went and did an extensive training of it actually this last year. And so I'm more familiar with it now. And I really wish that there was more of an ACT-based approach in it. But there are pieces for sure that come from ACT, even in the treatment model. So
aside from your treatment model, are there folks using ACT for trauma?
Yeah, in the general population, absolutely. Using it with adults. Not sure if they're using it with kids.
Right.
But ACT is really globally applied to so many different kinds of things that plague the human condition, really.
Yes.
So, yeah.
It would be surprising if there wasn't an application for trauma, for sure.
Yeah. Dr. Robin Wessler,
Yep.
she specializes, she's out of California, I think, and she was one of the presenters, and she specializes in treating veterans from an ACT-based perspective. So they're all in PTSD.
Okay, so let's dive into your model. What'd you come up with? What are you doing?
Well, I was working with Joe, so it's a multi-component treatment package. So it's got a lot of different components to it, and then so there's like the treatment package, and then we also had the components that we thought we should consider for individualization of the treatment package for all the different cases that we're working with. And I really feel super strongly that anybody who's working, and implementing different treatments with individuals with trauma has to be flexible in what they're doing. Like, everybody's going to respond and should be so sensitive to the client. But in general, we had a component of implementing functional behavioral assessments, and we've talked about that a little bit already. Developing behavior support plans specifically for parents. So teaching parents how to be change agents in the children's homes, provided that the children aren't living in care or something like that. Doing behavioral skills training with parents as well as a component of the package, making sure that we were collecting data and doing ongoing evaluation of the outcomes of the intervention. A really big piece, obviously, is going to be to teach appropriate emotion regulation. So instead of emotion suppression, learn how to be present with your emotions through mindfulness practices, and progressive muscle relaxation training was another component of it. Teaching emotion recognition. So one of the things that is really interesting, if you look at individuals who've experienced trauma, they have a really hard time naming emotions in other people. They make a lot of mistakes. Yeah. And also, so then you have a kiddo on the spectrum who can't necessarily name emotions in themselves and also can't necessarily name emotions in others. Now they've experienced a trauma, so it's even harder for them. So emotion naming in both directions would be a component of the treatment package for sure. Sometimes when it's okay to do it, implementing graduated exposure to memories of the trauma, for example, but that can be really highly contraindicated in some cases. You wouldn't want to do it. You would have to stop it, for example, if it led to the emergence of suicidal thoughts or depression or anything like that. So that was a piece of our model. And then things like making sure that you have more sessions. Like a traditional CBT program is typically 12 weeks in length, but increasing the number of sessions because we know that our learners need more time to acquire skills and to learn new things. Also decreasing the session length if needed. So instead of an hour-long session, maybe a 30-minute session is more appropriate. Cognitive restructuring could be a component for some people who have more advanced language abilities. Teaching about trauma and what trauma responses look like and what they are in the body. Providing parent and child support between sessions is super important, I think, for anybody undergoing any kind of trauma treatment intervention of any sort, just being present between sessions, because a lot can happen between sessions for kids who are in therapy. Developing a safety plan if there's a re-traumatization that happens, and if a kid needs help, for example, and then making sure that we program for generalization and maintenance. So that kind of was those were the different components of package. And then all the different pieces where you may want to change what you're doing depending on the client that you work with as well.
Right.
There.
And would definitely a multi-component package, Joe style for sure, which is awesome. I did my thesis with Joe as well. I know the experience. He's got an incredible work ethic when it comes to research, and he's a bit of a guru when it comes to sort of the PBS approach. And so I totally understand applying that from a bunch of different directions. I know one thing that Joe does like to do is is kind of bring other folks on board. I mean, there's a lot of stuff in here. Some of it, is familiar to me, certainly the BST and the FBA and all that kind of stuff. But then there's some stuff that, maybe I don't know as much about. Would this be a package that would be entirely implemented by a BCBA, or would there be other folks?
Absolutely not. The intention behind it was I was really interested in working not just within the field of behavior analysis anymore. And so that's specifically why I expanded beyond behavior analysis. There's so many areas in here that are outside of our scope of practice and knowledge, really, right? And so the whole premise would be to work, if you were going to implement something like this, to work with people who are experienced in counseling, experienced in psychology, or to acquire skills and training that then allow you to do this, right? So, I mean, this was just a suggested model based on the existing literature. So there are for sure things in here like graduated exposure. Yeah, we know what systematic desensitization is as behavior analysts, but graduated exposure to traumatic events, that's like way outside of our scope of practice.
Absolutely,
right?
Yeah.
Cognitive restructuring, even I would say many of us don't have any kind of experience with that.
No, not at all.
Yeah, but lots of us know how to teach emotion regulation, just maybe not these ways. We know how to program for generalization and maintenance and so on, and build safety plans. But really, there's components here that were explicitly designed to be outside of the realm of behavior analysis, for sure.
A couple areas I wouldn't mind hearing a little more about. I know you said we did talk about it a little bit with Camille Kolu's work, but I think folks would like to hear, and I would like to just hear more about kind of what a trauma-informed FBA looks like. Like, what's the difference?
Yeah, so a trauma-informed A is going to look at, like I said, the differences in the intensity of the problem behavior. So has there been a change in its intensity? Has there been a change in the quality of the behavior or its magnitude? And then has there been a change in the behavior, or is there a new behavior that has emerged? So there's those components to look at. And then also what I've been starting to learn about from Dr. Kolu is looking at the client history, and then putting that within the framework of a setting event and setting event analysis as part of the FBA process as well. Also, she talks about in her work going to the deeper function. And it's so weird because I've been also saying a very similar phrase for what feels like a few years now. It's like our FBAs look at the reason why the behavior is occurring in the first place. But if you understand trauma, you often understand that there's more that's happening covertly. And I think when you start to get into that covert stuff, things get so messy for us as behavior analysts, right? Like, are you a radical behavior analyst or not a radical behavior analyst? And where do you put covert over behavior on in your work and in your treatment protocols and stuff like that? And so I think where she's getting at that kind of stuff is the more covert stuff that goes on below the surface. But it's really important. Is there a way to measure private events essentially as a component of your FBA? And how do they then, where are they responsible for the behavior problems that we're seeing, right? Yeah.
The third secret word is regulation. Is there a way to measure that? Because I guess I see where kind of that's where maybe the ACT piece might come in a bit. But I like the idea of just because we already look at intensity and we already look at behaviors, but we don't sort of break that down and kind of look a little closer, because sometimes we're not going to get that client history that sort of tells us, came from this home or lived in this place and that sort of thing. And so just having those indicators to kind of look a little closer, I think is really neat. And it almost seems like those should be kind of standardized questions. I know some folks will just the interview sort of portion of an FBA, they just kind of will do on the fly, kind of do the W5 questions and kind of ask things. Yeah. But then there's other places where there's these structured types interviews. I know a lot of folks in kind of the world of PBS are all still using, the O'Neill et al. book there, and the FAI. I know it was, I think it was redone in 2015. I don't know how much different it was from the 97 version, but, maybe we should be seeing some of these kinds of questions sort of just being, embedded in those things.
I mean, like, even it is related, even things like asking, if your learner declined his school today, when the parent or the caregiver, whoever is responsible for drop off, how did he or she sleep last night, right? We know sleep is a setting event, but sleep is also severely affected in people who've experienced trauma, right? And so, like, not only is sleep a setting event for most humans, right? If you're sleep deprived, like, come on, think about how you function and how you operate in your environment. But then if you are every single night not sleeping because you're having like memories of the trauma, you're waking in the middle of the night and stuff like that, right? So that's asking about,
that's a good point.
Did the kids come to school with food? Have they eaten today? And then looking at, like, oh my gosh, every single day the parent says they don't eat breakfast. Why are they not eating breakfast, right? So what is going on from that perspective? And, the US and Canada are so different. Our population is so small, comparatively speaking, and the number of children in care here is so many. There are so many fewer children in care here in comparison to the US, and so I think a lot of the issues that come up in the conversations and in different kinds of sessions, like in the US, they're vastly different than what we see in here and talk about here, just because our population is so much smaller. We don't know, how many. We don't hear regularly enough about all the kids who are in care who come to school hungry, right? And yet they're in care, and so we assume that because they're in care, they're being fed well, they're at least their physiological needs are being cared for. But in fact, they're being neglected when they're living in care. And then they come to school and they come to school hungry, right? And so now they can't learn, but now they're also triggered because they're hungry for like the 10th day in a row when they come to school. And so that's where we don't see so much of what's going on when we're talking about kids who've experienced trauma.
That's so fascinating. The idea of looking at kind of these setting events and these sorts of operations that are in place, and we just sort of look at, like you said, poor sleep, doesn't eat much, or didn't eat breakfast. Do
you have proper clothing? Are you dressed warmly?
Right.
On a wet, rainy day? Every time it's wet and rainy, do you come to school with not the best clothing for that situation? And, that's neglect, and whether or not a person is intending to neglect. And so that's where it's really hard, right? It's like, well, by pointing that out, by saying, well, that's neglectful behavior, it then sounds like you're judging the caregivers, whoever the caregivers happen to be. But really, as people who work with highly vulnerable populations, if we can try to break away from that judgment and really come at it from the perspective of, like, you're doing your best under the circumstances with which you've been thrown into, and this is not your fault, but I need to find a way to help you improve your life so that your child or the child that's in your care's quality of life is going to improve. Where we should be coming from with all this. So
totally. I'm just thinking, when we dig into those. So when we have those kinds of setting events, often our solution is, or our intervention is, okay, let the kid have a nap. Okay, give the kid a snack, or lower your expectations that day. And we think those are sort of the interventions that are going to, as the PBS folk like to say, eliminate and or neutralize and and make irrelevant those setting events. But if you consider them from a trauma perspective, they're way deeper. It's not just that he didn't have a good sleep last night. It's that there's a trauma component, and we don't put a trauma related intervention into place. And so that's mind blowing. Just the idea of you're blowing my mind today, Alexia. It's wicked. So cool. But so scary at the same time. I wanted to touch a little bit on emotional regulation. We kind of talked about this when we met a couple of weeks back, and this is another area that I don't have a lot of knowledge in. And then we talk about sorts of breathing exercises and things like you said, like the progressive relaxation training and sort of some of these sort of standard, I don't want to say Well, yeah, they're standard in kind of the PBS realm, and then they're probably standard in other places as sorts of being go-to strategies to kind of do emotional regulation, but there's not much else. But you touched on a point that was a whole new term for me that I never even considered, this whole idea of kind of co-regulation and the necessity for that, even in, older folks that maybe have no emotional regulation skills. Can you kind of just explain that again and what that looks like and what that's about?
Yeah, for sure. So there's a big area in psychology that looks at co-regulation skills. And the whole idea is that us as being interconnected beings, we don't learn to self-regulate without learning how to co-regulate. And so co-regulation is what happens between a mom and her infant over, probably millions of learning trials, if you had to look at it as a learning trial of some sort, right? But it happens over like countless numbers of trials where the mom and the infant, and then the mom and the toddler, and then the mom and the young child are building the ability to eventually one day in the future regulate emotions effectively, but it's done as a dyad initially. And we talked about, how with typical kids, if your child is crying, if they're dysregulated, if they're flopping to the ground, many, many, many parents they're going to pick up their child and they're going to try to soothe and comfort them before they go anywhere else, right? Like if we're talking about a toddler who's flipping out because it's time to eat dinner and they don't want to go eat dinner, most parents are going to be inclined to go and approach their toddler, help their toddler come down, and then bring their toddler to the dinner table, right? We're not going to leave our toddler flipping out, crying on the ground, ignoring the tantrum until they're ready to come and eat, assume that they can regulate by themselves. And so, parents go and they soothe, they comfort, they hold their kids, they rock their kids, they rub their kids on the back, they rub their kids on the head, and so on. And that happens together. And the calm, steady state of the parent is what teaches the child to then reflect back that calm, steady state, right? So that happens together. The two people together are regulating. And then over time, eventually, your child can self-regulate across a broad range of contexts. And as they get older and older. And so the same goes for, I believe in, progressive muscle relaxation training and mindfulness is showing quite effective across a really broad range of different populations and stuff like that. But this whole of, I'm not going to expect you to regulate your own emotions if you can't even regulate your emotion with me, within the context of you and I together. That's a pretty big ask of someone to, hey, go regulate by yourself over there in the corner with your little calm down box, right? Use your breathing card, breathe in, that's right. Count to 5, 10 times all by yourself. Come on. So I didn't have to do that growing up. Why should anybody else? So,
and would you see co-regulation as being a strategy that you'd put in a plan?
Yeah. Sorry, we totally talked about all of this a couple of weeks ago when we were talking. So co-regulation is written into my calm down plans for my learners, whether or not they have experienced a trauma. So instead of, ignoring any kind of maladaptive behaviors, if a child is crying, if a child is upset, if the child is throwing materials off the table, I actually remove demands in that moment and I help them calm down and regulate. And each client on my caseload will have their own calm down plan, basically, that looks different for them depending on their own set of circumstances and histories and stuff like that. And then once they're calm, then we go back to work. And we don't go back to work until they're what we call socially engaged. So again, social engagement comes not from behavior analysis. That comes from just the general psychology literature. And they have to be capable and ready to learn. They have to be at least looking at me once in a while. If they do engage in eye contact, maybe they smile a little bit when I speak with them. They are physically capable of being in proximity to my body so that they can be close to me while learning, right? Sitting across from them or something. And so I look at these social engagement behaviors, right? It's really easy to operationally define what that looks like before I start to present task demands again. So,
okay. So then that makes perfect sense to me, but you're going to hear from people that are going to say, okay, but you're reinforcing the problem behavior. You're letting them escape from the task, and you're giving them attention. Like what are you doing? Is gonna be kind of the question you ask. So what do you say to that?
Yeah, I'm giving them attention because they're human and they're communicating with me in whatever way that they know how to communicate right now, that they're under some sort of distress. And I think that it would be inhuman and potentially traumatizing to ignore those signs of distress in our learners. And then in terms of giving in and letting them escape, that kind of stuff is really easy to control for in a learning environment, right? Like if I had 6 programs to do on my schedule today, and as long as I get through those 6 programs, my learner hasn't escaped the task demands that I've, had on the table from the get-go. We're going to do these programs and it's going to be what it's going to be. But first I'm going to help you calm down. Yeah. If I notice something like, all of a sudden we've gone from being able to do these programs for this many minutes in a session to really consistently, all this is like, every time, this program comes out, this is what happens, and it becomes super predictable. Yeah. Of course, I'm going to change my method. Of course, I'm going to be a behavior analyst and make sure that I have a procedure that, is effective at getting them to do the work that really ultimately we're trying to get them to do in sessions. But more often than not, I've found that teaching kids to calm down, to co-regulate, just leads to better emotion regulation, and we get more work and not less work done. And it's perfectly logical. The kid at school who's able to regulate their emotions effectively at school learns better and learns more. And the same is going to happen in a one-on-one intensive, ABA program, or, not early intervention, but still ABA program with older learners, right? You have to be emotionally regulated in order to be able to learn. Yeah. So can't learn under distress, essentially.
Yeah, and I think what you're describing is, I think, what a lot of these advocates now that we're, kind of going back to what we talked about earlier, these autistic advocates and whatnot are looking for. I think they're looking for, they're not looking for us to sort of tell them that, we have research to support our work, and they're not looking for us to tell them that, we don't do it that way anymore. I think part of what maybe they're looking for us to tell them is we can take a trauma-informed approach to kind of everything we're doing. And, it sounds like you've come up with a really nice way to have a trauma-informed approach to kind of, that sort of discrete trial kind of environment where, if folks are struggling, we can work on teaching a different skill. We're going to work on teaching regulation, because this is a great opportunity to do that, and co-regulation is kind of, the first step to that. And so, it sounds beautiful. So I wonder about kind of more older folks or adults and that sort of thing. I know I work with some cases that are kind of a little, complex and definitely a definite trauma history, with these cases, a known trauma history, for sure. Kids are kind of, we're not talking about kids anymore, young adults. So, in their 20s or whatever, living in a kind of a residential kind of setting. I know not necessarily, your experience level, maybe kind of more severe maybe more kind of appearing like an early learner type thing. So maybe less language and whatnot. Yeah. Would you? So self-regulation tends to be something a lot of folks are looking for. How do I help this guy calm down? How do I help this guy relax? A lot of them will say we've tried the calm down strip. The count to 10 and breathing and whatnot, and and they tend to be really good at blowing out candles after the training goes for a while, or blowing bubbles or whatnot. But they're not actually getting air into their lungs or anything like that. Just doing the blow sound. In fact, I had one kid who had years and years of the calm down strip, and it was and echolalia. They it kind of spoke with some echolalia, and it says time to blow. Was every time they had a little upset or whatever, I'll go blow, and then they would just blow a bubble and then leave. Yeah. But can we would that be effective for adults too? Sort of that co-regulation approach.
Well, I'm going to kind of flip it around on you for a second. Think about yourself when you're upset. Some people respond with leave me alone and get away from me, and I'm just going to deal with this on my own.
Yeah.
But like, let's think about, I don't know if you are single, not single, or whatever, if you have a partner that you live with, but if you're upset and it doesn't have something to do with your partner, right? Do you want to be left alone, or would you rather be calming down and processing with somebody else around you?
Yeah, I mean, I totally want to be able to talk it through. Maybe have a hug. Maybe just kind of sit down and a pat in the back, or just I get it, that sucks, that sort of thing, for sure.
So inherently, like even as adults, we do a lot of regulation with our partners, and there are times where you're in conflict with your partner, and you're like, yeah, I'm not interested in this right now. I'll talk to you in a few hours. But so much of our ability to regulate happens in the context of another person. And so, when you think about those adults that you're working with, you're right, like the population of people that we work with is different. When I work with an adult, they tend to have quite a bit of language and so on. But still, it's be with that person, just be there while they are calming down. Eventually they will calm down. They're not going to be in a heightened and an overly aroused state endlessly, right? And so do you need to walk away from them? Do you need to turn your back on that person because they're engaging in a problem behavior right now, right? Or can you work on developing a plan that involves some level of co-regulation that's appropriate within an adult context, right? And build a plan around that and that particular adult. And if that calm down strip isn't working after 10 years or 5 years, then change the approach and try to just like sit, offer different things that they can use to help themselves calm down, but don't walk away from that person, right? Just stay in their presence and allow that to happen. And maybe that will help you in the creation and development of a different kind of calm down plan. You're not going to be rocking an adult, right? You're not going to you're not going to rub an adult's back, right? But you don't need to walk away from the adult either and assume that they can do it on their own, because they likely can't do it on their own. So, and eventually they hopefully they'll learn how to. Hopefully they'll have better resilience and better ability to withstand hard emotions. And I think that's a big piece too, is like not just calm down, but and that's where the mindfulness, the meditation stuff comes in. It's being able to withstand harder and bigger feelings comes as a result of direct practice being in those feelings, right? And so that doesn't come from a calm down breathing strip.
So how do you get from co-regulation to mindfulness?
Starting to incorporate mindfulness practices just by starting to incorporate different kinds of practices. So things like mindful hearing. I mean, everybody probably who studies ABA knows about the meditation on the soles of the feet that was developed by behavior analysts. It's possibly one of my least favorite meditations. But anyways, mindful hearing, mindful breathing, body scans. And so you can incorporate these into your teaching within an ABA program, and you can develop measurement systems to see if they're able to follow along during the meditation while you're teaching it. Are they then able to self-monitor and practice independently on their own, and are they able to then use the strategies when they need to outside of the context of the learning environment? So you can absolutely design and develop measurement systems to see if your teaching methodologies are effective. And so we'll start with like very short with little kids, like a 5-minute sitting, or even shorter if we have to, right? And whether we're working on mindful hearing and having a child attend to different sounds in the environment, or like what we call the raisin exercise, or that's where you taste and sample a small bite of really healthy food and learn how to be really present with that item, and then expand on their range of mindfulness practices and slowly build up the endurance, like their ability to withstand the meditation component as well, into their instructional programming. And then gradually over time, we go from that co-regulation piece to, being able to self-regulate when they need to self-regulate. Really, it's about, can I stay calm when I need to stay calm when I'm on my own, right? Because more often than not, we have people around us to be with us at least, right?
Right. So cool. So cool. I know one thing that trauma is a bit of a scary topic for some folks in terms of kind of like addressing it. I think maybe with younger kids, actually, maybe it wouldn't even matter sort of about the age. But I've definitely run into this sort of situation where, folks feel like, and I maybe for good reason, because of their self-assessing competence and whatnot, but folks feel like they don't have the enough knowledge about trauma. They think trauma belongs in some other realm, belongs to those specialized people over there with the 3 PhDs, or the person from that trauma-informed center or whatever that is, or the addictions folk core. Basically not us, and somewhere else. And so they're even kind of afraid to kind of go there and even assess for that kind of stuff, because they feel like maybe once they open that box, there's no closing it, and now there's lots of risks and things. And so what do you say to folks to sort of maybe alleviate that fear a bit, and maybe you haven't seen it, but B, to sort of start kind of developing more of a trauma-informed approach?
It's totally terrifying to venture and to learn in this area, for sure. And how do you go about doing it? Take baby steps, seek supervision, find people who are able to help you learn about what it is first, right? Don't ever go in assuming that you can treat the trauma. Like, I never treat the trauma with my clients. That would be way outside of my scope of ability, right? It was my intention, and it is my intention, by continuing my education, to be able to go and do that one day. But you're not there to treat the trauma. And I think that that's like a really big thing that needs to be driven home. I'm not there to implement a trauma protocol in order to help with treatment. I'm there to assess for it. Assessment is built into everything that we do, right? And Dr. Coley talks about that as well. It's you learn how to take data, you learn how to pinpoint behavior, and you learn how to measure behavior. So that is not outside of our scope of practice. Go and attend learnings and workshops. There's lots available. There's less available directly within the field of behavior analysis. But I mean, if you're willing to enter like contextual behavioral sciences and kind of go into that area, then you can learn there, and you can get supervision there, and take coursework if it's an area that you're interested in. So you're not allowed to learn, right? Nobody said you're not allowed to learn. What people do say is you're not allowed to practice outside of your area of competence, right? And so if you want to develop a competency in that area, then it's totally on you to develop a competency in that area, whether that means you do another degree, whether that means you do trainings and don't actually go and treat trauma, for example, but you just want to know more about trauma. You want to be able to walk in and do an assessment and know, feel more confident in what you're looking for and observing, and then bring that to a team of people that you work with. And so, for kids who are identified as having experienced traumas, they typically have a team of people that supports them. It's not just a BCBA, but there'll be, a psychologist or a counselor involved. There'll be a school team involved. There'll be social workers involved as well. And so you're not working in isolation at that point anymore. You have a very big group of service providers, right? It's super collaborative and very PBS-y in so many ways. So
yes, and I think that's a key point there around, we don't have to treat the trauma. When we don't have to think about having to do that, because that's not kind of our role. I wonder, and I like the idea of kind of you have to go outside the field. I think this is the piece where with trauma there, because like you said, there's not much research, and because your paper shows there's not a lot of research on trauma and autism. We've got no choice but to sort of go into these other realms, counseling, social work, or whatever, and kind of dive in there. And I think that sort of speaks to a greater point for those maybe folks who are still getting certified or newly certified, that competence isn't just going to be memorizing the Cooper book or some other ABA type text, and that you're going to have to kind of go outside the box. I know I'm going to be interviewing Hillary McClinton and Nicole Shallow down the road on sleep and whatnot. And actually, they told me that they had spent a lot of time sort of diving into, research that had nothing to do with ABA, but that was vitally important for them to kind of gain competence in that area. And so it's the same thing with trauma. And we can really it's venturing outside the box into kind of other areas. And also, I think this also speaks to, a piece that we often kind of hear about, and I think we're getting better in areas like this, that, BCBAs and ABA folk, they don't like to sort of play nice in the sandbox with, other professions. But, this is a great way to sort of, dispel that myth as well and start kind of linking with other professionals. So I think that's really cool.
I really think that really quickly we need to get over ourselves.
Yeah.
Like I'm so sick and tired after almost 20 years, nearing on 20 years of hearing that ABA folks and BCBAs don't play well in the sandbox. Like, and it's not just, us talking about it openly. The number of times I walk into any kind of school-based meeting, daycare-based meeting, and nobody wants to know who I am. And that speaks volumes as to how unapproachable we are as a field, right? Like I, for example, explicitly today tried to stay away from a lot of terminology that was going to turn this into a behavioral jargon fest. And that's just because the terminology comes from other fields. And why do we have to go and change it, right? Why do we have to take a pre-established language, set of words that are used to describe certain events and certain phenomena and define it behaviorally? And I think that any time that us as behavior analysts are going to go into kind of stickier areas, whether it's mental health issues, sleep-related issues, trauma, I don't think it's appropriate for us to then walk away, change the definition so it's in behavior speak, basically, and then talk about it that way. Like that makes us unapproachable. That makes people hate us as professionals. So I'm pretty tired of that. So.
No, absolutely. And for a group of folks that's supposed to be super knowledgeable in reinforcement and super knowledgeable in transferring properties, we suck when it comes to doing it with other people.
Yeah. I'm just going to go punish your behaviors now. I'm going to tell you that you're wrong and I'm going to piss on your parade. Like what? Yeah.
Well, it's because we're in behavior and everything's a behavior, therefore we can do everything. I mean, and I think that's sort of been a general attitude for a long time. And it's just wrong. So that's pretty cool. I think it's pretty cool just to see that we're seeing more and more people specializing in different areas and realizing that the only way they're going to become specialists is if they venture outside of the field. And the only way that they're going to be able to teach others is to encourage others to venture outside of the field. So I think this is a good move for us and maybe a good move for our field. So I think that's pretty cool.
Totally. Pat Farman always talks about how ABA needs to go outside of autism, but the only way we're going to get there is by changing ourselves drastically. So
100%. And I think that's a good sort of segue to possibly having you on again. I know we really wanted to talk about, definitely having you on again. We really wanted to talk about, I think, the ableism and kind of how that is in our society, in our field, and kind of how that relates to trauma. And I think we wanted to chat more about kind of how has ABA shifted over time and how hasn't it, and those sorts of things, and kind of how we can just kind of do better as a field and really kind of speak more to ABA reform and a lot of that stuff, which I think would add several more credit hours to this podcast, which, if folks want to earn them, I guess we could keep talking, but my throat's getting dry. So I think maybe we'll just kind of leave it with is sort of any sorts of, kind of final thoughts that you'd want to kind of share with listeners, share with folks that are interested in kind of getting more into this area.
Mm-hmm. I mean, there are lots of talking about resources and I guess how to learn and stuff. So there are lots of different places where you can go and learn and acquire skills and so on. You and I were chatting the other day, there's a bunch of different Facebook groups out there, and that's not somewhere where you're going to go and get educated in trauma, but at least being a part of that community is a good start. So I'm honestly right now, I'm just looking for my list that I have written down. I wrote down a pretty extensive list here, but there's different groups on Facebook. Like there's Trauma Informed Schools is a good one. Trauma ACEs from an applied behavior analysis perspective is another one that you could join. There's the Listen, Learn, Do Better that you kind of just touched on as you were chatting there. Acceptance and commitment therapy support groups, the contextual behavioral sciences group. And then to actually get, ongoing training outside of behavior analysis, Praxis has a lot of awesome CEUs available, even for BCBAs actually on ACT therapy and applications of ACT. There is the National Institute for the Clinical Application of Behavioral Medicine. They put on a lot of good CEUs. Not that we can collect those CEUs, but if you're a psychologist or a counselor, you can. There is the Central Reach CEU on assent and withdrawals of assent that I think that I would, ties into trauma and ableism and everything kind of together. There's, like we talked about, Cusp Emergence University that Dr. Kolu has developed, and she has her blog, but she also has CEUs available on there. Those are awesome. I've taken some of those and I've been learning so much through those.
Cool.
Yeah. And then there's a whole pile of people that you can read as well that are outside of ABA, but they're like the gurus in trauma. So
if somebody wanted to get some supervision as it relates to trauma, is that something you'd be into? Or
I don't feel that I necessarily am capable of doing that quite yet. I feel like I have a lot left to learn. Yep. I could help direct them, maybe a little bit where to go and resources and stuff like that. I hope one day in the near future to be able to do that, but I'm not competent enough in that area yet.
Perfect.
So.
Good. Well, and excellent to recognize that. And I know you'll get there. So that's super awesome. Well, I want to thank you again for being on here. This is super cool. You were my first person to reach out to me about being on the podcast, which was super honored for that. And so great to have this chat and learn a lot more about trauma and kind of how it affects autism. Looking forward to seeing more of your work. Looking forward to that Volkmar book coming out. And
me too.
And
I can't wait.
That'll be pretty exciting. You've shared a ton of resources, which we're going to have all available for folks, including your article. And yeah, just thanks again for being here.
Thank you so much. It's been fantastic talking to you, and it went by so fast. I can't believe it. Yeah.
Cool.
We're looking at 30 almost.
That's right.
So I'm super honored to have been here today. Thank you.
Awesome.